Hi guys, I'm ready to go through a summary of what's going to be on the final exam. Let me start off with telling you that there will be 40 questions on the final. The calculations that you need to know, I will enter it here. All right, so I think I got it straight. So 40 questions. The calculations that will be on the final include the following. Cardiac output. And remember, cardiac output is the heart rate times the stroke volume. If you're given the stroke volume, that's great. You just plug it into the equation. But if you're given the end diastolic volume and the end systolic volume, you have to subtract them from each other to find out how much blood was ejected from the ventricle. So if the end diastolic volume is 100 mLs, and after the heart contracts, there's 50 mLs left, or the end systolic volume is 50 mLs, you just subtract and you come up with the amount of blood that was ejected from the ventricle. And that's the stroke volume. So heart rate times stroke volume equals cardiac output. The next, craziness. Okay, the next formula you have to calculate is ejection fraction. And remember that ejection fraction is the amount of blood, or the percentage of blood that is ejected from the ventricles when the heart contracts. So if the heart is healthy, it typically ejects about 55 to 60% of the volume in the ventricles when the heart contracts. However, if a patient is in heart failure, the muscle is weak. When it contracts, it doesn't put out as much volume or stroke volume. So the ejection fraction will be low. So 35% and less is considered severe cardiac dysfunction. The formula for ejection fraction is comparing the stroke volume to the end diastolic volume. You come up with a fraction and you change it to a percentage. So if there's 50 mLs ejected from the ventricles, and there was 100 mLs before the heart contracted, it would be 50 over 100 is 0.5, or 50% for the ejection fraction. The next equation you have to know is mean arterial pressure. And this is when you take the systolic blood pressure, you add 2 times the diastolic pressure, and you divide that number by 3. Because the heart is in systole 1/3, it's in diastole 2/3. So normal mean arterial pressure is about 93 millimeters mercury. When the mean arterial pressure is higher than 106, that's considered hypertension. The next equation is systemic vascular resistance. So it's abbreviated SVR. This is looking at the amount of resistance in the entire blood vessels from the beginning, which is the aorta, to the end, which is the right atrium. So how much resistance is in the systemic vasculature? So in order to calculate this, you have to know your beginning pressure, which is going to be the pressure in the aorta. And we can use a blood pressure measurement, but you can't just plug in blood pressure. You have to figure out the mean arterial pressure first. That would be your beginning pressure. Then you subtract your ending pressure, or the right atrial pressure, also called CVP. So that's the pressure. And then you divide by flow, which is cardiac output. Then after you divide those two numbers, you multiply by 80, and that's going to change that number into units of resistance. So the units for the answer will be in dynes per second per centimeter to the -5. So normally systemic vascular resistance for the adult falls between 900 and 1400 dynes per second per centimeter to the -5. If the vessels constrict because of heart failure, or they constrict because of hypovolemic shock, the numbers will be higher. All right, so that's it for calculations. Now I want to tell you about the rhythms that you have to know. So let me put it over here on the other side. So you have to be able to recognize certain arrhythmias. And then the next question will ask you, how would you treat this arrhythmia? So you've got to learn both. Okay, you have to know normal sinus rhythm, of course. Sinus bradycardia. So sinus bradycardia is defined as a heart rate less than 60 beats per minute. And when you come across treating sinus bradycardia, if the patient is unstable, then yes, it needs to be treated. The primary medication is atropine. That's going to block the parasympathetic system, allow the sympathetic system to speed up the heart. Sometimes a bradycardia is caused by a heart block, and then a pacemaker would be needed. Just a regular sinus bradycardia gets treated with atropine. If the patient is asymptomatic, it could just be they're athletic, they have a high ejection fraction, and their heart doesn't have to beat as many times per minute. So you only treat it if the patient is symptomatic with altered mental status, chest pain, diaphoresis, and low blood pressure. You have to recognize and know how to treat sinus bradycardia. I said that already. Sinus tachycardia. So when the heart is beating faster than 100 per minute, so 100 up to 160 per minute, we call that sinus tachycardia. And it's could be because the patient has a fever, maybe they're having a lot of anxiety, pain, that's going to cause the heart to beat faster. The treatment for sinus tachycardia is to treat the underlying condition. So there's no special drug that needs to be given. It's just treating the underlying cause. So if the patient is in pain, then you need pain meds. If you have sinus tachycardia because the patient is hypoxemic, you give them oxygen. So you treat the underlying cause. The next rhythm you have to know is the ventricular dysrhythmia. For example, frequent PVCs. I'll just leave it at frequent PVCs. So when you have like a normal conduction, and then you have a PVC, and then a normal conduction and a PVC. So PVCs are occurring very frequently, like every other impulse. That's called bigeminy, and you treat the ventricle by making it less excitable, and that's by giving amiodarone. So amiodarone slows down the calcium channels, the sodium channels, and that will kind of stop that overstimulus that is occurring in the ventricles. So amiodarone is used for treating frequent PVCs. Another ventricular arrhythmia you have to know is ventricular tachycardia. Or VTAC. So VTAC is a very unstable rhythm, and the patient could have a pulse with this rhythm. Neurologically, they can be responsive, but we're very concerned because VTAC can quickly deteriorate into ventricular fibrillation, where you're not going to have any pulses, or it could deteriorate into pulseless VTAC. So the patient has to be monitored very carefully. So to treat this arrhythmia, if they have a pulse, if they're stable, there's time to give some amiodarone to stabilize that ventricular muscle. And maybe there's time for cardioversion. So let me just say that there's a difference between cardioversion and defibrillation. You cannot use those two words interchangeably. Cardioversion, you have to have a QRS for the EKG machine to recognize, so it knows exactly when to deliver the energy or the shock. So the amount of cardioversion is much lower than defibrillation, and cardioversion has to be synchronized with the EKG rhythm. So the only time you're going to use cardioversion with VTAC is if the patient has a pulse and they're stable and there's time to cardiovert. Once the patient becomes unresponsive and loses their pulse with VTAC, it's no longer cardioversion that has to be done. Now it's going to be defibrillation. Defibrillation does not line up with the QRS. It delivers a much higher energy charge. So VTAC without a pulse is when you're going to use your 200 joules with your biphasic defibrillator. Of course, you start CPR as soon as you don't have a pulse. You defibrillate immediately because that's what's going to give the patient the best chance of surviving that cardiac arrest. And if they don't get converted, that's when you give your milligram of epinephrine. You let that circulate every 3 to 5 minutes. It needs to be given again. So after circulating for a minute, now it's time to defibrillate again and see if the patient's heart will respond to that second shock. The next arrhythmia you have to know is ventricular fibrillation. Or the abbreviation of VFib. So as soon as you see this on the monitor, you check the patient, because a disconnected lead will look exactly like VFib. And remember, when you're trying to figure out, is it VTAC, is it VFib? With VTAC, your QRSs are wide, very fast, but very regular. VFib is a chaotic looking rhythm. There's nothing like norm, not, I don't want to use the word normal. There's nothing organized with VFib. So it's just chaotic firing of the ventricles. So with VFib, you should not expect a pulse. So you have to check your patient first, just in case the lead came off and it just looked like VFib. So if you check the patient, they're no longer responding and they were responding right before that rhythm, that means there's no pulses, but you check a pulse anyway and you start compressions, you call a code. You would treat pulseless VTAC and VFib the same way. CPR, immediate defibrillation. And then epinephrine to be given first. If after the second shock, after epinephrine's given, the second shock is given, and still the patient is not converting, that's when amiodarone is indicated. Thought I was going in order, but I skipped SVT. So let me put it here now. So SVT is an abbreviation for supraventricular tachycardia. Supra means above the ventricles, so it's an impulse originating above the ventricles, and it's a very fast rhythm. So a lot of the times we don't even see P waves because the QRS has already occurred. So we don't always have P waves with this really fast rhythm. We know that the impulse is starting above the ventricles because the QRS is its normal, 2 to 3 little boxes, or what do we say, less than 3 little boxes. So we know that the impulse is going through the AV node and it's going down into the ventricles normally. And the way we know that is because the QRS is narrow or normal. It's just a really fast rhythm. So supposedly the SA node only fires about 160, possibly 180 times per minute. If you have an atrial rhythm that's faster than that, there's an assumption that there's something else initiating all of these impulses in the atria. So supraventricular means somewhere in the atria, these really fast impulses are originating. So for a patient to have a heart rate of 180 per minute while they're laying in a hospital bed, that should not be happening. So how can we slow down that really fast rhythm? Adenosine is given. It's given twice. Like first time it's given with 6 milligrams, and that doesn't work. They'll wait like a minute or two to see if the patient's rhythm converts and slows down. If it doesn't, then they'll give a higher dosage. They'll give 12 milligrams and see if that works. If that doesn't slow down the heart rhythm, then they'll try using cardioversion. There's also medications that can be given to slow down the heart rate, like the calcium channel blockers. The beta blockers will also slow down a really fast heart rate. All right, and then what's left are the heart blocks. First degree heart block is just a real long PR interval. The reason it's taking so long for the impulse to get from the SA node through to the ventricles is possibly because of ischemia. So if there's ischemic muscle tissue, infarcted muscle tissue, conduction doesn't go through that area very well, and it'll take longer to get through. It could be the patient's on medications, and the medications are slowing down conduction through the AV node. We talked about digoxin. Possibly I think the calcium channel and beta blockers can also cause first degree heart block. But it's considered an asymptomatic arrhythmia, so we don't have to do anything with first degree. With second degree heart block, there's two types. Second degree type 1 or Wenckebach is when the PR interval gets longer, and then you have a dropped beat. That's all you need to know about that for your exam. Second degree type 2. You'll have a P wave that does not conduct through to the ventricles at all. There'll be another P wave. It may or may not get through the AV node to the ventricles, and then another P wave. So you could have like 2 or 3 P waves before one of them actually makes it through the AV node into the ventricles. So that's considered a more serious arrhythmia. It's treated. My brain just stopped working with a pacemaker. Oh my word. It's treated with a pacemaker if the patient is asymptomatic with that, but that is considered an unstable rhythm. And then third degree heart block is when the atria, the atrial conduction does not go through the AV node at all. And of course, when the ventricles are not getting any impulses from the atria, they start generating their own impulses. But what you'll see on that EKG rhythm is there will be a slow ventricular rate, and all the QRSs will be wide. So you'll see a slow rate and wide QRS. I think I said the ventricles depolarize 20 to 40 times a minute. And then, of course, the first rhythm that pulled up, it had a heart rhythm of 50 per minute. But nonetheless, it's very slow, and there's no communication between the atria and the ventricles. Okay, so we went through all the rhythms that you have to know for the final on Tuesday. I'm going to pause. Oh, I have 5 more minutes. I can keep going. I'm going to pause the recording. I have a meeting at 3, and then I'll finish recording this. For questions on the exam, oh, I know, I want to go through the hemodynamic handout. So let me close the whiteboard. Share the screen. And there are questions on hemodynamics. And you're going to need to be familiar with this sheet. So the different conditions that we talked about, and how can you tell the difference between cardiogenic shock, ARDS, septic shock, and hypovolemic shock. So those 4 conditions, as they're called, have like little, what is the word I want? You're able to tell which one is which based on whether you have pulmonary edema, what your pulmonary artery pressures are, what your pulmonary capillary wedge pressure is, cardiac output, SVR. So we went through this in class. Let me just do it very briefly, and then we'll answer the questions. With cardiogenic shock, the left ventricle is not functioning well. And when the left ventricle doesn't function well, blood flow backs up into the pulmonary system. And when you've got blood flow backing up into the pulmonary system, wherever you have blood volume, you have increased pressure. And that backed up blood flow will cause increased pressure in the pulmonary vessels and in the pulmonary capillaries. It's called increased hydrostatic pressure. Well, that increased hydrostatic pressure will cause fluid to leak out of the capillaries. When the fluid leaks out of the capillaries, the fluid goes into the interstitial spaces of the lungs. And if it gets worse, then it goes into the alveoli. And when the patient's coughing, they'll be coughing up this fulminating pulmonary edema. So that's fluid that left the blood vessels, went into the lungs, and now they're coughing it out of their airway. So when you look at fluid in the interstitial spaces on the x-ray, or if it's in the alveoli, you're going to have a lot of fluffy white infiltrates. So that's evidence of pulmonary edema. Another thing that happens with cardiogenic shock is because all the blood is backing up into the pulmonary system, the pulmonary artery pressures will be high. With a Swan-Ganz catheter, when that balloon is wedged into a vessel, it's going to read pressures over on the left side of the heart, and that will be elevated again because the heart's not pumping effectively. Blood volume backs up, and where there's volume, there's pressure. So you're going to have a high wedge pressure. So those are the clues that you're looking at cardiogenic shock. Of course, systemic vascular resistance will increase because the body is noticing it's not getting much cardiac output from the heart. And the body responds by, I guess, tightening or constricting the vessels, and that will help to divert blood flow to the major organs and protect the major organs from that low blood flow. Give me 1 second. All right, so let me keep going. The ARDS, the telltale signs that a patient is in ARDS is there will be pulmonary edema. Their pulmonary artery pressures, I think I told you variable. They are increased if the patient is hypoxemic. So remember, the pulmonary vessels constrict when there's hypoxemia in the arterial blood. The vessels constrict if there's acidosis, but as far as a hypoxemia, they'll constrict if there's hypoxemia. The pulmonary capillary wedge pressure will be normal. So there's nothing wrong with the left side of the heart. The left side of the heart is functioning normally. So you'll have pulmonary edema, possible increase in pulmonary artery pressures, but the wedge pressure will be normal. So those are going to be your clues that you're looking at ARDS. With septic shock, we have an infection in the body, and the response of the body to a massive infection is vasodilation and capillary leakage. So the patient presents with a really low blood pressure, really fast heart rate. With the capillary leakage, there is pulmonary edema. So really low blood pressure, pulmonary edema, And then the heart responds by having a high output, so high cardiac output. So those are the clues that you're looking at septic shock. Hypovolemic shock, there's loss of blood volume, all your pressures will be low. The body responds to really low pressures by constricting the vessels. So you'll notice the systemic vascular resistance is increased. Okay, I'm going to pause the recording. I have a meeting and then I'll finish up. Okay, I'm ready to continue. Why does this happen? Yes, so I'm being recorded. In order to continue with this hemodynamics form and the different clinical conditions, we made it all the way to pulmonary embolus. With pulmonary embolus, there's a blood clot that's traveling in the vascular system. And blood clots can travel from smaller vessels into larger vessels, into larger vessels. But when the vessels start getting smaller, then the blood clot gets lodged. So that's why we get pulmonary emboli. A blood clot can start in the veins, travel up to the right atrium, the right ventricle. But when it gets into the pulmonary vessels, the vessels start to get smaller and smaller on their way to the lungs. And that's where the blood clots lodge. So what hemodynamics are going to reflect the fact that we've got blood clots. The pulmonary artery pressures will be increased, but only if there's enough blood clots or lots of blood clots, occluding like a lot of the vascular bed, then we'll see increased pulmonary artery pressures. Other than that, you're not going to have pulmonary edema. You're going to have hypoxemia, and that's about it. Okay, and then the last category is mechanical ventilation with PEEP. And when we put a patient on the ventilator and we add PEEP to their settings, that positive pressure in the thorax can cause less blood to return to the heart. So the positive pressure kind of impedes venous return to the heart. So low blood pressure, PEEP will make a difference. It will prevent blood from flowing back to the heart. However, if vascular volume is normal, when we turn on PEEP, we don't see any changes. Then if PEEP is more 15 centimeters water and higher, the positive pressure will squeeze the pulmonary vessels and make the pulmonary artery pressures look high. It'll make the pulmonary capillary wedge pressure look high. Then if you turn the PEEP down to 5, all of a sudden your pulmonary artery pressures become normal. The wedge becomes normal. So high PEEP will interfere with the readings for pulmonary artery pressure and wedge pressure. So that's the takeaway point with mechanical ventilation and PEEP. All right, now to answer the questions. So question 1, if the clinical picture presents with pulmonary edema on chest X-ray, pulmonary artery pressures are not affected, the pulmonary capillary wedge pressure is not affected, the cardiac output is high, 9 liters a minute for an adult, systemic vascular resistance decreased. What is the patient's condition? And the answer is septic shock. So we get the pulmonary edema because of capillary leakage, and it does not increase pulmonary artery pressures. It doesn't affect the wedge pressure, but we do have pulmonary edema. We've got high cardiac output. And then the blood pressure in septic shock is really low, and so is systemic vascular resistance. So just think massive vasodilation, low blood pressure, high cardiac output, you've got septic shock. All right, the next clinical picture, number 2, we have pulmonary edema on chest x-ray. Pulmonary artery pressures are elevated above normal. The pulmonary capillary wedge pressure is elevated above normal. Cardiac output is decreased. So we have a heart that's not functioning well. Systemic vascular resistance is increased. What is the patient's condition? And the answer is cardiogenic shock. So high pulmonary artery pressures because blood backed up into the pulmonary vessels. High wedge because the left ventricle is not putting out blood. Decreased cardiac output. So we're looking at cardiogenic shock or left heart failure, congestive heart failure. Clinical picture number 3, we've got a pulmonary edema on chest x-ray. Pulmonary artery pressures are possibly elevated, but the pulmonary capillary wedge pressure is normal. So if the wedge pressure is normal, that takes away left heart failure. Cardiac output is normal, systemic vascular resistance is normal, and that leads us to ARDS, where we've got pulmonary edema and possibly high pulmonary artery pressures. So that's the sign that we're looking at ARDS. Number 4, if the clinical picture presents with normal chest x-ray, pulmonary artery pressures are lower than normal, pulmonary capillary wedge pressure is lower than normal, cardiac output is lower than normal, but the systemic vascular resistance is increased. What is the patient's condition? And the answer is hypovolemic shock. So low pressures everywhere. We've got low volume, and that's called hypovolemic shock. Right, the 5th question says, assume a patient has normal blood vascular volume. Pulmonary artery pressure is 35/15. Pulmonary capillary wedge pressure is 14. And those units are in millimeters mercury. The patient is on PEEP of 15 centimeters of water pressure. What change would you notice in the pulmonary artery pressures if the PEEP is decreased to 5 centimeters of water pressure? And the answer is the pressures would decrease because the high PEEP is creating falsely high pulmonary artery pressures and a falsely high wedge pressure. So high PEEP gives us false PAPs and a false wedge pressure, falsely high. And it's just like an external squeeze on those pulmonary vessels, and that's why we're seeing falsely high numbers. Number 6, indicate the distinguishing parameters which lead to the diagnosis of pulmonary embolus. So our pulmonary artery pressures would increase because we've got occluded blood vessels. There has to be enough of them occluded, of course. The pulmonary capillary wedge pressure will show normal because there's nothing wrong with the left heart. Cardiac output varies. Dead space ventilation increases. So when you have pulmonary blood vessels blocked with blood clots, there's a bunch of alveoli that are not getting any blood flow. So if you don't have ventilation matching up with perfusion, you're going to have a lot of wasted ventilation. So your dead space ventilation will increase. The PaO2 will be decreased with a pulmonary embolus. And again, because we don't have good ventilation perfusion matching. Number 7, if a patient has a systemic vascular resistance of 800 dynes per second per centimeter to the -5, what medication would improve this hemodynamic? So we've got low SVR. And we would use Levophed, epinephrine, or dopamine, which is a vasoconstrictor, and that would increase the blood pressure. Number 8, if an adult patient has a cardiac output of 3.5 liters per minute and a cardiac index of 1.9 liters per minute per square meter, that's kind of low. We want our cardiac index to be 2.5 and better. So to have it 1.9, we don't have enough cardiac output for the size of this patient. And it asks, what medication would improve this hemodynamic? And the answer is milrinone, which causes the heart to contract more strongly. Same thing with digoxin, and the same thing with dobutamine. So they increase contractility, so they're called inotropic agents because they increase contractility. All right, so that was the hemodynamic sheet. Now let me just go through some questions that you'll need to know for the test. You need to know the treatment for asystole. So asystole, we've got no PQRST, nothing. We've got a flat line. We've got to check to make sure it's just not the leads disconnected. Call for the patient, no response, check a pulse, there's nothing. We've got asystole. How do we treat that? We treat it with CPR. The medication that can be given is epinephrine. Do we defibrillate asystole? The answer is no. You have to have some sort of ventricular activity going on in order for defibrillation to make a difference. So you can't shock asystole. Okay, I'll just go in order. Why do we pressurize a bag of sodium chloride with heparin in it when it's attached to an A-line? So the reason that the bag is pressurized is because it has to flow against a back resistance. And the back resistance is the pressure in the artery. So if you have a catheter sitting in the radial artery, there's a lot of pressure in the radial artery. And if you put a catheter in there, the blood will push into the catheter and start coming out the catheter. So how do we counteract that pressure? And the answer is by pressurizing a bag of saline with heparin and pushing it through to counteract that pressure that's in the artery. Next question, when you're looking at an arterial pressure waveform on the monitor in the patient's room, you're going to notice it looks like a blip on the pressure waveform. Every time the heart beats, you've got this little almost like an artifact, but it's called a dicrotic notch. And that occurs when the aortic valve closes. So that's a question. It's going to ask you about the dicrotic notch on an A-line waveform. And the answer is it occurs when the aortic valve closes. There's a question on the relative refractory period on an EKG. So the second part of the T wave represents a time when the muscles in the ventricles are repolarizing. So at the peak of the T wave, some of the ventricle has repolarized, some of it hasn't. And it messes everything up if an electrical charge is delivered to the heart during the second half of the T wave. Second half of the T wave has a name. It's called relative refractory period. And if a shock is delivered during the relative refractory period, it'll put the patient into ventricular fibrillation. Pulmonary artery pressures with hypervolemia. We talked about that already. So here's some questions on aortic balloon pump. How does the aortic balloon pump help the heart? So it helps the heart two ways. One of the ways it helps the heart is it decreases afterload. So it makes it easy for the heart to contract because there's a big balloon sitting in the aorta. It's about 10 inches long. It's really long, and it sits in the aorta, and it deflates right before the heart contracts. Well, when the balloon deflates, there's no blood in that part of the aorta. So now the heart can contract against no back resistance. So that's one way it helps the heart. The second way it helps the heart is when the balloon inflates, it pushes the blood in the aorta into the coronary vessels, and it really helps to perfuse those coronary vessels. When does the intra-aortic balloon inflate? So it inflates during diastole or right after the aortic valve closes. Okay, and then there's a question on a low bicarbonate in a patient with a low cardiac output. What is the connection? So patient's got a low cardiac output, you draw a blood gas, and their bicarbonate is like 18 milliequivalents per liter. Why is the bicarb so low? So the connection between low cardiac output and low bicarbonate is when you don't have enough oxygen delivered to the tissues of the body, anaerobic metabolism takes place, and the byproduct is lactic acid. So lactic acid becomes a marker of poor oxygen delivery to the tissue. And it's one that is measured on a lot of the blood gas machines now. So you need to know why bicarbonate is low if a patient's cardiac output is low. And it's because there's not enough oxygen delivery to the tissues, and lactic acid will start being produced during anaerobic metabolism. Name the rhythms that respond to cardioversion. So fast atrial rhythms, so SVT or atrial tachycardia is another name. They respond to cardioversion. VTAC with a pulse may respond to cardioversion. Rhythms that respond to defibrillation, there's only two: VFib and pulseless VTAC. That's it. Okay, and then there's a scenario where it mentions how a patient has an A line in, but the blood pressure was taken with a cuff. The blood pressure in the cuff shows 120/70 millimeters mercury, but the A line 70/50 millimeters mercury. Why would the A line read so low? And it gives you some choices. So one of the things that we know is if the transducer is not level with the right atrium, it's going to cause abnormal readings. If the transducer is too high and the blood has to push upward towards the transducer, it's going to cause a lower than normal reading. It could be that the catheter is kinked or not sitting in the artery properly. Make sure you review your notes for induced hypothermia. Remember, this is cooling a patient after return of circulation post-cardiac arrest or patients that have a stroke. And the purpose of induced hypothermia is to decrease the amount of swelling that occurs in the brain when there's an insult to the body, such as cardiac arrest or stroke. So if you can keep the body cold, there's not as much swelling, and neurologically the patient does better. So you need to know the temperature. So it's between 32 and 36 degrees Celsius, most likely 36, because there's really no difference in outcomes if 32 degrees is used or 36 degrees is used. It has to be started within 6 hours of the insult or the injury. And make sure you adjust your blood gas temperature on the blood gas machine when you're running your blood gas. I might be beating a dead horse, but let me ask you the question anyway. What pressures are high with severe hypoxia? Is pulmonary capillary wedge pressure high if there's severe hypoxia? Are pulmonary artery pressures high with severe hypoxia? So the answer is with pulmonary capillary wedge pressure, it will not change with severe hypoxia. Pulmonary capillary wedge pressure is a reflection of the left ventricle and how well it's pumping. It's not a reflection of hypoxia. So the wedge pressure would be normal, but pulmonary artery pressures are high when there's hypoxia. What could cause a low venous oxygen saturation? Normally we want to see 75%. We want to see a PVO2 of 40 millimeters mercury. But if it's lower than that, what does that mean for us? It means that the cells are extracting more than the normal amount of oxygen. It could be because the cardiac output is low. It could be because hemoglobin is not adequate, like a low hemoglobin, you're not getting enough oxygen delivered to the tissues. It could be a low arterial oxygen content. Let's say we're standing on Mount Everest and the partial pressure or the atmospheric pressure up there is like 500 millimeters mercury. So 21% of 500 millimeters mercury, that's not much oxygen. So we start off, what kind of hypoxia is that called? If we're breathing in really low amounts of oxygen. I think hypoxia, if we're breathing in low amounts of oxygen. So that could be another cause for low oxygen delivery to the tissue and a lower than normal venous oxygen saturation. All right, next question. Why do we pour 5 cc's of blood into a reservoir with the VAMP system before drawing an A-line arterial sample? Why is it that we have to pull some blood into a reservoir? And the answer is we're pulling blood that has the heparin in it out of the tubing and getting a fresh flow of blood from the patient's body. If we draw blood with the heparin in it, the heparin has a pH of 7.0, so it'll cause inaccurate reading from our blood gas. Make sure you review the effects of the transducer level, the effects of a transducer being higher than the right atrium or being lower than the right atrium. And that's all I've got. I wish you guys well. I know you're going to do well. You're going to study, prepare, and then this is it for cardiopulmonary diagnostics. I know there's a few of you that'll stay after the exam on Tuesday and go through the VFib VTAC algorithm. So we'll be expecting that also. All right, signing off.